Well, good afternoon, everybody. I'm Juan Bustillo. It's my pleasure to introduce Dr. Javier Ortiz Orendain, who has been with us for the past year. Dr. Ortiz went to medical school in Guadalajara, Mexico, and he did his residency in psychiatry at the Mayo Clinic in Minnesota. After that, he did a fellowship for a year at Yale in the area of clinical management and comprehensive management of first episode psychosis. And then we were very fortunate to recruit him to join us here. He's been working at the COPE Clinic and at the early program with us for the last year. And now he is the director of the early program. And I'm excited to hear his presentation. It's something very provocative, I think, on prevention of schizophrenia. I've actually never heard a presentation in this area in my 30 years working on this area. So I think we are up for something very interesting. Go ahead, Dr. Ortiz.
Thank you, Professor. Yeah, so I really have been interested in this topic of schizophrenia prevention. As really my expertise is in early intervention and in first episode psychosis. But also one of my big interests in psychiatry is complexity, psychiatric complexity, and so I start, by disclosing that I don't have any conflicts of interest and that the images in this presentation are part of the public domain. And I start off with a Karl Jaspers quote that says that we have to be content with partial knowledge of an infinity that we cannot exhaust. As a kickstart to embrace the complexity, embrace the uncertainty when we are dealing with psychiatric problems. These are my goals. Really, the main goal is to just have a better understanding of the complexity of schizophrenia prevention. And for that, I'm going to talk about risk factors. And I'm going to try to do it at different levels of analysis, starting from the micro and then elevating to more complex levels, including social levels. I'm going to distinguish between what is a prodrome and what is a clinical high risk for psychosis. And then I'm going to talk a little bit about early intervention and early detection for psychosis. So to start, we got to understand the huge public health problem that schizophrenia is. Schizophrenia costs the United States $343 billion a year, and this is a paper in Journal of Clinical Psychiatry. Most of the money for the money spent for schizophrenia is in caregiving. But we have all of these expenses that are associated with this, with only very, very few of our money spent on research and training. So this is the problem that hopefully, if we can prevent this problem, we can reduce the burden to the economy. Schizophrenia is obviously one of the top 10 global diseases that cause the most burden to society. So I kickstart with this question that I asked everybody to hopefully put it in the chat if you have any idea. I don't think there's any right or wrong answer. And I've asked this question before to students, to residents, and I usually get very different answers. So the question is, what would you do if we give you $5 million and you have the task to prevent schizophrenia in New Mexico? This is, very tiny amount of what it really costs to schizophrenia. So if anybody, we can start having a chat filled with some ideas. I really feel that the prevention of schizophrenia, given that there's not, as I'm going to try to describe, there's not going to be a very clear answer, that it allows for a lot of creativity if someone has a creative intervention. Anyways, so I start there. And This is what prevention looks like in mental health. This is the Fusar Police work. Really, most of us in medical school learned about primary prevention, secondary prevention, and tertiary prevention. Primary prevention in this case is subdivided in universal prevention. An example of universal prevention is, for instance, folate administration to moms. We give it to everybody gets it. Selective intervention will be, for instance, vaccinations for people in certain groups that are at risk, such as the pneumococcal vaccine for people that are above certain age. I want to talk about a specific indicated prevention with a psychiatry example. So if we want to prevent something, the first task is to try to find the etiology. In the context of schizophrenia, we tried, and we have not done a lot of progress in terms of what is the cause of schizophrenia. But we know a lot about risk factors for schizophrenia. And so the idea it will be to try to reduce risk factors as possible. But how would you do it? I mean, it's not only like describe the risk factors, but also is it feasible? Is there any intervention that you can make at different levels of analysis to achieve this? So I start with genetic risk. Genetic risk is one of the answers that I sometimes get, especially from med students that tell me, hey, no, you put more money on, give $5 million to study more genes. So I'm going to talk about where are we in terms of the genetics of schizophrenia. So in 1962, James Watson, was supposed to attend a conference, but he couldn't make it because his son was having a mental health crisis. This was later diagnosed as schizophrenia, and James Watson, as a controversial figure that he has been, he said this: I soon realized that his troubles lay in his genes. That drove me to lead the Human Genome Project. The only way I can understand our son and help him live a normal life at a normal level was to decipher the genome. James Watson, has been criticized for being a biological reductionist, but here we see that at that time already we were thinking that the answer for curing and preventing schizophrenia was in the genes. So in 1990s, fast forward 1990s, there's also, George Bush Sr. says, this is the decade of the brain. There was a lot of optimism, a lot of progress. The Human Genome Project was started. Olanzapine was being discovered. So there was all of this sense of progress that things were really going to change for schizophrenia. But this is part from the extract of this recent paper by Torrey that says that in 1995, the NIH director said that everybody could forget about the enzyme research, MRI, CT studies, PET scans. That if you were not studying genes in 1995, you were going to be dinosaurs. So imagine the sense that the genes hold the answers to human disease at that time was, I was not there, but it sounds like everybody was very optimistic. Now, we know that, at least in schizophrenia, there's a lot of genes that are associated with this, a lot of variants, a lot of SNPs that are associated with schizophrenia, but even if it has a very good performing GWAS study and the what has been described the best performing polygenic risk score, we can only experience very little of the variants of what causes this disease. So as Torrey concludes, he says that we are no better off today than we were in 1985 when when the Human Genome Project was first suggested. So here we are. So what can we do at the level of the genes? I find my first roadblock. I don't think so. I mean, I don't know if anybody here, I come from an institution with a big psychiatric genetic tradition, and I just don't see that the answer for schizophrenia lies there. Maybe one day. But what can be done if you will put the money there? So there's two interventions that I think have happened at this level. The first one is mother nature intervention, as I call it. That is that most people with schizophrenia will never have children. Actually, according to this study, schizophrenia is the mental illness that has the lowest fecundity rate. So even if you have all of this like evolutionary selection pressure to remove all of the genetic variants associated with schizophrenia, there doesn't seem to be any change in the incidence prevalence of schizophrenia. There's this. I have this idea that schizophrenia just seems to be an illness that is part of the human condition. It seems to be like necessary for the human condition. Another attempt that was done was during World War II. There was what it has been described as the greatest criminal act in the history of psychiatry. Hitler, requested that every person that had a mental illness that required institutionalization will be, as I'm quoting, prematurely terminated. So they killed over 200,000 people with schizophrenia, and the study around 20 years later, where you will expect that the effect of the intervention will start to play a role, compare a study in Dublin versus a study in Germany, same time, and it seems like somehow, even after, killing all of these people with schizophrenia, the incidence had already normalized. So, at this point in time, I just don't see that there's anything that we can do at the preventive level at the preventive genetic level. I'm gonna switch to the next level, which is the perinatal risk factors. This is a meta-analysis also by Fusar-Polly. Fusar-Polly is the PI of this. I only have extracted those factors that were statistically significant, and I put the heterogeneity. So there's all of these factors associated with prenatal and obstetric risk. Giving good care to a mom is essential. I think we are already doing it. Or at least we are already attempting to do that. Care at this level is universal, because giving good maternal care will not only prevent schizophrenia, will prevent a lot of things. So yes, this could be an area where this can be targeted, and hard to say. But again, similar to the genes, there are many obstetric factors that are associated with psychotic disorders, but all of these risk factors have very small odds ratios. So again, similar to the genes, many factors, small effects. The question is, what can we do at this level? There are a few interventions that have been done with the mom to try to prevent schizophrenia, although imagine the complexity of that method. But this is probably the most cited study on this. This is, I have the PICO question, which is healthy women that they are giving phosphatidylcholine, higher doses versus just dietary advice. And then they measure the P50. The P50 is a measure of sensory gating. The P50 has been considered a very reliable or a somewhat reliable biomarker in schizophrenia. The P50 is very good, a method for assessing children via these neurophysiological measures. So what they did is they gave the diet to the moms, and then they measured the P50 in the babies. And they did see this, this is 2013. They did see that the P50, the ability to inhibit the P50 response was improved in those that were treated with choline with a good effect size. Is this schizophrenia prevention? Maybe. Maybe it's so hard. We wouldn't even know right now. I mean, these kids are 10 years old right now. So maybe in 10 more years, they will publish and they will compare this. But this is so problematic because schizophrenia can occur in probably one of those kids, and so it will be so hard. You will need to have huge sample size, follow-ups of 20 years. It's just so complex to understand if an intervention that is targeted to prevent schizophrenia is successful. I do believe that obviously we should continue to provide good mental health or good maternal care in general. Okay, I'm gonna switch now to environmental factors. I'm gonna talk. I cannot talk about all of them. I'm gonna talk about a few. I'm gonna talk about immigration. So immigration is consistently described as a risk factor for schizophrenia. This is probably the largest study, the Swedish study of 1.3 million people, where it showed that the risk for schizophrenia in immigrants is around 2 for those that are non-refugees, and 3 for above 3 for those that are refugee immigrants. What is said about immigration that causes or increases the vulnerability for schizophrenia? There's this author, Thomas Fuch, that described that this is the loss of basic trust and familiarity with the shared life world. That is, we get into this world that now is unknown. People don't speak your language. People have different cultures. And that is really a shock to the psyche. This also happens with less immigration, but just moving to college as a critical time where people move out of their homes and go to this new town where all of their familiarity becomes altered. And that I do think that is a risk factor for schizophrenia. So what can we do at this level? I do see the trauma, of course, trauma, all of the trauma associated with immigration is obviously the co-founding factor. And we can see that those that experience adversity, likely the ones that come as refugees have higher incidence. So immigration can be, just co-founding the fact that it's just adversity, as most of these immigrants in Swedish come as moving to trying to find a better place. But intervention at these levels will be inviting immigrants, having welcoming space for them, helping them connect with the culture and learn the language. I can just imagine, I did experience that when I moved to the United States, the shock of like having these difficulties with language is a really stressful time. Helping maintain the community. So, potential interventions at this level, I think, yes, for sure, feasible. The $5 million, I think you can put it there, and they might go a long way. The other one that is kind of a joke, kind of not, but it's this. I don't know if anybody heard of John McGrath, but John McGrath is probably one of the most important psychiatric epidemiologists. He just published this in Schizophrenia Bulletin that just cat ownership is a risk factor for schizophrenia. And obviously cat ownership implies a lot of things, including, who prefers the cats, but also all of the parasites. Mostly all of the theories behind it involve the toxoplasma exposure. So I don't know, can we do something about the cats? Maybe. So I'm gonna talk about now cannabis. Cannabis, I get this one a lot, when I ask, hey, where would you put the $5 million? And people say marijuana. But where do $5 million go for marijuana? Like, the industry of marijuana is huge. Like, what would we do with that money? So there's this really very interesting study, very complex meta-analysis. This is also Fusar Foley's work, where he they conclude via this complex measure that is called the generalized impact fraction, that if you were to reduce the use of cannabis by 100%, you will prevent around 10% of the schizophrenia spectrum disorders. So is that feasible? I mean, but here we see how, and I will not talk about this because opening up the childhood adversity box will have opened up many possibilities. But the one that has the most impact, according to this study, is that if we reduce adversities in childhood, and I think that I've seen in the chat that a lot of people have been mentioning adversities in childhood as a critical area of focus for schizophrenia prevention. So again, as I was saying, how to compete with an industry that just in New Mexico in 1 year made $300 million? How can we do that? I think the nicotine, the nicotine experts, I know that there's a few here in the institution, the nicotine situation was successful. So can we make it unfashionable again? There is, I envision like warnings, warnings saying this cannabis is associated with schizophrenia. I think that's very clear, and we should put it, getting like more warnings, more awareness, ads. But as I say, I don't think making this as like a security problem by increasing the war on drugs is where we should go. We've had enough harm for that too. Oh, okay. So that is all for really primary prevention. I'm gonna move to, it's still under the umbrella of primary prevention, but it is called indicated prevention. So indicated prevention is that prevention that is advisable for persons who are found to manifest a risk factor, a condition, or an abnormality that identify them individually as being sufficiently high risk to require the preventive intervention. So imagine so for those to be able to say, hey, this person is at risk for schizophrenia, it's just something very challenging and something that really has had a lot of work done. We have been trying to predict who will develop schizophrenia for a long time. And there's really two ways of doing that. And I'll talk about them. But so this is really a very hard task. So you have to find them first. You have to say, this person is at risk, and then you have to develop an intervention that works to prevent schizophrenia. Now in a very peculiar population. So for that, there's really two methods that are used, which one of those are prodromal research. Prodromal research involves research that is retrospective. So it's on studies that are full of converters. It's a sample of people with psychosis, and you look retrospectively about what are all of these events that happen in the life of people that develop schizophrenia. Those are inexpensive, those are relatively easy to undertake, but the risk studies are those that are prospective, where you, depends on your models of how you think, you understand schizophrenia, you describe who is the population at risk, and then you follow them, and then you see who converts and who doesn't convert. We have Dr. Lenrud here, I think, and Dr. Lenrud is obviously, she has some work on this. So the prodrome is, I think this is important. A prodrome can only fully be described after the onset of schizophrenia. So you cannot say, in general, we are not, we should not be saying this person looks like he's prodromal, because prodrome, by the very nature of the word, has to do with preceding. So it can only be described retrospectively. But retrospectively, most patients will have a prodrome. And so around 80% of patients will have a prodrome in this most recent meta-analysis. I have some prodrome research, so I have to show a little bit of what I've done. My prodrome research is to look retrospectively in a sample of Minnesota, what happened before, all of the healthcare utilization that they had, all of the diagnosis, all of the medications, how much do they last, what substances do they use. And what I tried to do was to distinguish those that had schizophrenia between the and bipolar, to see if the prodrome of schizophrenia and bipolar looks different. But in general, the prodrome is a period of high heterogeneity. That is really, it looks different. It could look like ADHD and intellectual problems. It can look conduct disorder. It can be very depressive. There could be a lot of anxiety. There could be a lot of substance use. So really, the prodrome, is very hard to have anything that looks very specific to a prodrome. So really, I really feel that this is a case that prodrome mimics anything, and so that really is a challenge if you want to develop a preventive strategy that is selected for a selected population. So then there's this other concept of clinical high risk for psychosis, which is you try to predict who's going to develop psychosis, and then you see who converts, and then hopefully you can develop some interventions that can change the amount of converters. So this remains, clinical high risk for psychosis remains concepts that are to only be utilized in either highly specialized clinics or just highly specialized clinical research clinics. This is still not something that is ready to be developed, to be part of general clinical practice. Usually the diagnoses are made via structured interviews, either the SIP or the CHARMS. And both of them actually have tried to come up. One is American, the SIP is American, the CHARMS is from New Zealand, Australia. But they have tried to homogenize and develop these three concepts. That is APS. APS has made it to DSM-5, the attenuated psychotic syndrome. Is still in conditions for further studies, so maybe it one day will come. There's the BLIPS, the brief limited intermittent psychotic symptoms. Those are symptoms that psychotic symptoms that last less than 7 days, that just usually resolve by themselves without antipsychotic treatment. And then there's genetic and risk deterioration syndrome, which is someone that has a family history of psychosis and a decline in function. Anyways, how good are we at predicting who's going to develop schizophrenia? I really don't think that we are doing very well. Right now, of all of those people that get involved in these studies, that we label them and we say, you are at high risk for schizophrenia, only around 33% will convert. So we have a 2/3 of false positives. What does it mean to have a label as most likely an adolescent that you were at high risk for psychosis? So right now there really is an ethical dilemma of whether we should even be using this if our predictive power is so poor. And there's other conceptual issues. With these high risk terms. Is still being used. I hope I'm doing justice to these concepts, but so once you have them and you have to then involve them, you want to develop interventions to see if your interventions work and you can actually prevent schizophrenia. So then you get them in clinical trials, you do the SIPs, do the CHARMS, you develop, these are people with high risk, and then you randomize them, you do clinical trials and see if things work, and you can change even decrease the ratio of transition even further. CBT CBT for psychosis prevention works. This is the recent meta-analysis. So, randomizing these patients to CBT versus treatment as usual has, some effect. I mean, the risk ratio is 0.4 with zero heterogeneity. So that's, that seems pretty convincing, and that should be the standard of care for this population, CBT. But what about other things? Can we give them pills? Can we give them pills, and can we prevent schizophrenia by giving pills to people that are at risk? This has been tried. I was just getting interested in this field when I read the Omega trial. There was so much optimism at the time. After this trial was released, that just giving omega-3s for psychosis prevention was going in. After 7 years, they had, almost no one converted that had omega-3s versus almost, 10% versus around 40%. So it was, it was big. It was big, that trial. I thought that at the time I imagined that at the time everybody was very excited. And then they tried to replicate with a larger trial, the NeuroPro trial, 300 people. Same group that did this. And then, they just didn't find that omega-3s prevent schizophrenia. Okay. But what about antipsychotics? Can we give them antipsychotics to prevent schizophrenia? So Professor Toen, ahead of his time in 2006, 2006 was already trying to answer this question, where they recruited patients that were prodromal, or now we will call them CHR, the clinical high risk. 60 patients they recruited, and they randomized them to olanzapine or placebo. Trying to prevent schizophrenia in 2006 was really, really, interesting. That study almost made it. A p-value of 0.08, underpowered, but we can see that this is, the mortality curve of those that were placebo. It was 20% versus more than 40% for those that were assigned to placebo. So there was something, the olanzapine did gain a lot of weight, so that there were side effects involved with the treatment. Anyways, this practice of giving antipsychotics to people for the purpose of preventing schizophrenia is recommended against. This is a guideline for how to treat people with high risk, and really is recommended against. It's frequently used in practice, but it should not be used with the purpose of prevention, but more symptom management. Okay. I'm going to talk about secondary prevention now. So secondary prevention is really what we do at early. Secondary prevention is early diagnosis and management to prevent complications from a disease. So the first big problem of an early intervention clinic is, how do we find them early? How to find people that are having, there's people right now here in Albuquerque having psychosis that are not receiving mental health services, and psychosis is very destructive, and so it's causing a lot of problems right now. And so how can we find them early? Can we put money to try to find them early and reduce the duration of untreated psychosis, which is really a focus of many people in this field. So the duration of untreated psychosis for probably now 20 years has been understood as a factor that predicts prognosis. The DUP is a problematic concept because it's usually retrospective. That is, you get your patient first contact, and then you try to go back via interview to see, family, to see where it started. So there's also this problem where there's the problem of negative symptoms not resulting in help-seeking behaviors, and and positive symptoms being more disruptive and resulting in early help-seeking behaviors. Right now, or on the most recent community in community treatment settings here in the United States, it's estimated that the average duration of untreated psychosis is 193 weeks. The median is 74. Most participants tend to have a duration of untreated psychosis for more than 6 months. So these are people that have been sick in the community for 6 months and are just before they getting into their first contact. We see, we get patients in early that, have both, have gotten legal problems because of their psychosis, family problems. I mean, psychosis is really so destructive. So we need to find them early. It seems clear and consistent that the duration of untreated psychosis is a prognostic factor. This is the Oliver House meta-analysis that shows that in most measures, negative, positive, global psychopathology, functional scores, duration of untreated psychosis is worse. So the effects are not huge. They are actually relatively small effects, but it seems to affect the person globally. So we should attempt to reduce the duration of untreated psychosis. But can we do that? How can we do that? That really should be part of a mission of a program like Early. And in 2018, there was really no evidence that there was anything that we can do for this. That the duration of untreated psychosis was something that was happening, and interventions at the community level, training to healthcare professionals was just not helpful. Where I trained in New Haven, you could see these buses, and this is a little bit after. This is 2018, and this was a trial that was done by my mentor in New Haven. He randomized a clinic in Boston versus his clinic in New Haven, and in New Haven they did all of this, the mind map campaign, where they released awareness for the buses. There were social media ads, there was training in the community. So it was all of this campaign to raise awareness and reduce the DUP. It seems like he did reduce the DUP a little bit. He continues to publish on this work. It's not clear if the DUP results are clinically significant. But at least the DUP was reduced. So what would you do? I put the question, what would you do with these $5 million? And one of the leaders of the field has said that early intervention is the best bet. The best bet for a healthcare system is to intervene early to prevent further deterioration of this illness. And so in Early, we are delivering these evidence-based services there. These are some of the ingredients of Early. We provide evidence-based pharmacotherapy that includes, really trying to do low doses of antipsychotics. Since for the past more than 15 years, I think, around 15 years, there was a recommendation against the use of olanzapine as a first-line treatment. You can still use it, but it should not be first-line given its metabolic profile. We also aim to get people in clozapine early. There is people really delay the start of clozapine, so we should be doing early clozapine treatment in those that are good candidates. We provide therapy, case management. We provide education and employment support. We give, families. We provide family support and psychoeducation. We have groups. We have just a very successful group. this is one that I've been really focused on. People with schizophrenia die early, so we gotta reduce the cardiovascular risk, and that's one of the missions of an early program as a preventive strategy. We aim to be easy to access and hopefully to keep an open door. So if someone refers someone too early, we aim to respond quickly and determine if they meet criteria for our services to see them soon. And hopefully, right now we are developing the possibility of starting to measure ourselves to understand, who are the patients coming to our program, how are they doing, how are they presenting, how long is their DUP. So hopefully then we can, understand how well our clinic is performing and improve based on that, but also to produce research. This is the evidence that early intervention really works. Early intervention keeps people engaged, reduces hospitalization, reduces the risk of relapse, increases the chance of remission, recovery, and vocational engagement, and helps with most, in this meta-analysis by Correll, in all of the symptoms. So, the question is this the most cost-effective intervention? I put my money here. I mean, this is what I do. So, I have probably a bias here. And then the other question for us is, what happens after they leave? Are we does these effects linger and remain? It's not clear. Really, the most recent study, the Opus trial, really show that after 20 years, the people with schizophrenia that were in an early program or were treatment as usual tend to start to converge. Is this time for disappointment about this? I don't think so. I don't know of a lot of interventions that have sustained effects at 20 years. It will be, I mean, if you reduce the intensity of most services, the effect of the intervention will stop. Okay, so that's all I have. I conclude by saying, and I hope that everybody can appreciate the complexities of the task of schizophrenia prevention, understanding that there are many factors, small effects, and that finding a cost-effective way to reduce schizophrenia is challenging. I really don't think that there's, anything that is a right or a wrong answer. Given this, schizophrenia prevention allows for very creative intervention. I think that the best bet might be early intervention. This is my team, or the team of early. We have a great team, very experienced people, and so we are happy to serve the community of New Mexico and the people suffering from early psychosis. That's all I have.
Hello, can you hear me?
Yes.
All right. Well, that was very interesting. So I want to invite anybody. Fortunately, we have plenty of time to ask questions. So anybody, Bess, go ahead.
Bess is just clapping.
Oh, she's just clapping. Okay. All right. Okay.
Hi. I was just wondering if there was anything you could say about the people that are starting to study taking folks off of medications, either, at a relatively early if they've done well, or people who are wanting to go off of medications later on after first episode.
I actually did. Dr. Bustillo invited me to do a peer review for a very large trial like this. And it does seem, we do get, I mean, the question that I have clinically all the time is, person comes in after their first episode, they are in symptomatic remission, they look great, they have recovered completely. And the question for me is, can I take them off of the antipsychotic safely, or is the antipsychotic the thing that is keeping them well? You know, I think that there's this subgroup of people that can come off the antipsychotic that have a one psychotic episode and done. My understanding of the evidence is that from the clinical point of view, the predictors of who will have that is not very clear. What will guide that? If you know, Dr. Lenroot, what are the factors that can tell us who will know? But it's something that I really use shared decision making for these things. If they will continue engage with us, you know, if they will continue engage with early, and we can monitor them while they are coming off via a slow taper, because slow tapers and slow, I mean, we can talk one day about slow tapers, but slow tapers are very slow and it take months. Anyways, yeah, I think it's feasible. My understanding is that there's no clear clinical guidance as to who are those that never will need an antipsychotic again.
Okay. Dr. Toyn?
Yes, I like Dr. Lenroot is first clapping and then raising my hand. So it's a great presentation, Dr. Ortiz, and I do agree with Dr. Bustillo that it is great for the department that you joined. So question. So as we know, psychosis can be a lethal condition by self-harm. And first episode is actually in the course of the illness, it is a high risk. Most patients with non-affective psychosis, when they take their lives, it's early in the course of the treatment, as opposed to, contrary to common belief, those who've been ill for a long time. So do you know if there's any studies that have looked at early intervention? My guess would be that if there's something where early intervention is going to help in non-affective psychosis or affective psychosis, is going to be in the prevention of suicide during the initial years. And then let me make a comment on the question of when do we stop the medication. And I'm going to focus on the area of psychosis that I'm more familiar with which is the affective psychosis. So there is the concept that the longer you stay well, the better the chances you have of staying well, right? So then before medication was, I guess, incorporated in our treatment, in psychiatric treatment in the 20th century, if you looked at patients with bipolar disorder, once patients were in remission, this is without medication, for 4 years, the chances of staying well were very, very good. So being in remission 6 months didn't predict much. Being in remission, or even with medication, on medication, 1 year better than 6 months. So I guess so then the second question would be for non-affective psychosis. Are there such studies looking at the I guess the natural course of the illness, and that would give us an indication in terms of stop meds? It's a good practice with bipolar disorder where patients want to stop their medication, let's say because they want to become pregnant, and medication has its risk. When is the best time to do it if their choice is to do it off medication? And that could be 4 years. So what do you recommend in terms of non-affective psychosis? And again, congratulations for your presentation, Dr. Ortiz.
Thank you. Usually, my practice is to keep the patient on an antipsychotic for more than 6 months and at least a year, so that they both can also, with the help of our therapist, learn all of these skills, learn all of these things, you know, get educated about the nature of their problem, develop insight, and given and again, I do agree that the longer the stability, the less likely that the person is going to relapse. So that's why, you know, this arbitrary measure of around 1 year in my practice. And yeah, and then after you take them off, it's just hoping that they stay engaged and they stay stable. And if if the second time happens, then really, to me, if there's been 2 episodes, then really, I will very rarely recommend someone to come off of their antipsychotics. Yeah.
Yeah, that's why the second.
For the suicide prevention, I actually that's such a great question, but I need to look at the evidence for if early intervention has the impact on suicidality.
And to your point of once you have the 2 episodes, that you join the group of the recurrences. So in a way, the second episode is the most important episode, as you mentioned. The likelihood of not having another episode is small. Thank you, Dr. Ortiz.
Dr. Lenroot, you were gonna
I just wanted to add a comment about this question of, I think when you look at the relapse rates for people who come off medications with non-affective psychoses, they're pretty rapid and pretty grim. But it seemed like most of that has been people who've dropped out of treatment. And there's been some studies that are going on now that are really trying to say, well, if people remain in treatment after they've non-pharmacological treatment and have those sorts of supports and things, might it be not quite as awful as it looks for people who just dropped out. And as far as I know, and that's part of where my question came from, the last studies I've seen they're doing in the Netherlands and mostly overseas were maybe promising, but weren't definitive yet. But it's a question that comes up so much in you know, any stage, but certainly in first episode is, what does that mean for the rest of my life? And yeah, but thank you.
So there is, I'm familiar with the study, treatment strategies for schizophrenia, which was a study led by Nina Schooler and Sam Keith, who was our chair before. That study was not in first episode schizophrenia, where it was in patients with chronic schizophrenia, and it was really looking at likelihood of relapse. And the main question is, can we prevent relapse even if the patient is taking very little antipsychotic or no antipsychotic, if they are having very intensive family therapy? Yeah, and it was a big NIMH funded multi-site study, and the results were clearly negative. So it was very clear. Again, it's a different population than the first episode, but patients who have been stabilized on antipsychotics, reducing the dose and stopping the antipsychotics, regardless of the extra support, at least in terms of intensive family therapy, led to very rapid and predictable relapses. There was a question here by Dr. Sexton, and she's asking, and I'm looking at the chat. For Dr. Ortiz, in your study, was there any differences in the prodrome between bipolar and schizophrenia patients? The quality of the prodrome, the characteristics of their prodrome?
Before my study, you know, Christophe Correll, big researcher in schizophrenia, had a study that he said that they are indistinguishable. In my study, there was very small. They were the quote that I have in my paper is, they are more alike than different. But really, bipolar disorder had more affective problems before the first episode, and schizophrenia had more neurodevelopmental problems. There were no difference in exposure to medications and use of substances.
Okay. Any other questions? I see a question in the chat by Hermes Santiago, but I wouldn't do it justice just reading it. So, I mean, are you there, Hermes? You want to ask your question? Are you still there, or are you gone?
No, I'm here. I Dr. Ortiz, you said that you mentioned something about lifespan in children, and my question is, if we're working with a young population now, and they're probably not thinking about children and not thinking about the future, so how would you present that information if they're asking something about, I want to have children, and how would that affect me into the future?
Let me see if let me clarify the question. Is it someone that has had a first episode and is wanting to have a baby? Is it about that?
Yes, I mean, they're not thinking about having children today, but they may think about having children in the future.
Okay, yeah. So we have, there's probably in the audience there's people that take care specifically of the perinatal psychiatrist. My understanding of that is if one of our patients were to want to get pregnant, we will still provide them with the psychiatric care that they need based on their needs. If they need antipsychotics are not contraindicated in pregnancy. So we will treat them with all of the supports and all of the services that we have. Just by the nature of the heritability of schizophrenia, just by the nature of the heritability of schizophrenia, they have certain risks, but the idea will be to mitigate risk via good prenatal care, and just reducing all of the other risk factors that are modifiable.
All right. Well, I think we can finish a couple minutes earlier. Thank you to everybody for their attendance, and thank you very much, Dr. Ortiz, for your presentation.
Thank you. Bye.